Hello and welcome to this session of Maritime Medicine in which we discuss mass casualty incident triage. By the end of this session, you'll be able to define a mass casualty incident and perform primary or initial triage in a mass casualty incident using the simple triage and rapid treatment system. So what is a mass casualty incident? Anytime your resources are overwhelmed by the number and severity of patients. So this can be when there are more patients than providers, or if you have other people coming, there's more patients than rapidly available providers, or some agencies or services define an MCI as more than X number of patients, 5, 10, whatever, and that's typically based on their own known resources and what they can get available to them. And this is related to an acute event as opposed to being chronically understaffed. So for example, you're on a ship, you're the only person who's qualified to provide medical care, no one else can help you, and you get 2 or 3 patients at a time from a explosion or a fire. That's sort of chronic understaffing, but conversely, you now have a single incident that has caused multiple casualties that overwhelm you, so that becomes a mass casualty incident. But had there been appropriate staffing, it might not be a mass casualty incident. Now, managing mass casualty incidents is beyond the scope of this class, but the idea of managing an MCI is to do the most good for the most patients with the resources you have available. And so you need to be able to sort out patients by their needs to determine who you're going to do the best for. So you do something called triage, which is the sorting process so that you can do the most good for the most patients with your limited resources. Triage is French for to sort, and the patients will be sorted based on their needs for care and the acuity of those needs. That is, are they likely to die within an hour without care? Are they likely to die within minutes without care? Are they likely to deteriorate or die within a few days, or are they unlikely to deteriorate? So patients will get multiple rounds of triage, and we're going to talk just about the initial triage here, but when they're gathered somewhere, either a treatment point or another gathering point, they'll get a secondary triage, and then inside that care point, they'll get tertiary triage, and then when they get to their destination facility, they'll get quaternary triage. So the sorting process goes on again and again and again, and it becomes finer and finer and more detailed. But your job in responding to an initial event, say you're asked to assist a fishing vessel that's had an engine room fire and explosion with multiple injured crew, you happen to be the closest vessel, you respond, you're going to do the initial triage, and then you may do some of the secondary triage as well. So there are over 20 systems around triage, and you need something really simple that you'll be able to remember, something that's relatively universal. The CDC has recently tried to create an evidence-based triage, and that's called SALT triage, which is sort, assess, life-saving interventions, treatment, and transport decisions. This has not been universally accepted yet. If you look into what a lot of agencies use, they use something called START triage, simple triage and rapid treatment, which was initially described in the 90s. It's easy to use, it's easy to remember. In Maine, it's the protocol for EMS providers, and it's based on 4 basic principles. If people can walk, if they're ambulatory, then they're less ill, and we initially triage them as green. Dead people consume too many resources, and so the dead and the near dead are triaged as black or expectant. Identify everyone else really ill but salvageable. These are people who need interventions within a 60-minute period, or you can expect them to significantly deteriorate. Those are red. And then anyone left over after you've done that sorting is yellow. So how do we do this? You look at the group of people in front of you and you shout, "Can you walk? Move over there." Everyone who does is green, and we categorize them as minor, although in secondary triage, additional injuries may be identified that would increase their priority. Then we do RPM. R is breathing. If they're breathing, spontaneously, then we assess the rate. If they're not, they get one shot. So if they're not breathing, you open the airway. If they start breathing again, they're tagged red or immediate. If they don't start breathing again, they're still apneic, they're tagged black or expectant. And those are people that are unlikely to survive regardless of the care that we can give based on what's going on in this mass casualty incident. So when you get back to them, and we will, your treatment priorities may be a little different. However, if they're breathing spontaneously, you check their respiratory rate. If it's greater than 30, they're tagged an immediate. If it's 30 or less, you move on. Then you check a pulse. That's the P in RPM. If the radial pulse is absent or their capillary refill is greater than 2 seconds, they're tagged immediate, a red. If the radial pulse is present or their capillary refill is less than 2 seconds, you move on to the next assessment, which is M for mental status. If you tell them to wave their arm or move or respond to you and they don't obey commands, they're red. If they do obey the command, then they're yellow. So you've basically got these points where you can knock them out. If they're breathing greater than 30, you don't assess any further. They're red, you're done. You move on to the next patient to triage them. If they're breathing and they're breathing less, 30 or less, then you check a pulse. If the radial pulse is absent, or you check capillary refill and it's greater than 2 seconds, you're done. They're red. You don't continue to do your assessment. You move on to the next patient and triage them. But if the capillary refill is less than 2 seconds or the radial pulse is present, then you check their mental status. You ask them to obey a command. If they follow that command, then they're yellow. If they don't follow the command, they're red. So you've got those points where they fall into red and you don't do any further assessment. And if they don't meet those, then they keep going down until they fall into yellow. So now let's do some scenarios here just to get the idea. So patient 1, you say, everybody get up, walk over there. They walk on command. They are green. Patient 2 doesn't get up and walk. They're breathing. Their respiratory rate is 22, but the radial pulse is absent. You're done. You don't have to assess anything else. They're red. Patient 3 has a respiratory rate of 14. Obviously, they didn't get up and walk when you told them to. The radial pulse is present, and they follow commands. You're done. They fall into the yellow catch bag. Patient 4 is not breathing. You open their airway. They're still not breathing. You're done. They're expectant. They're a black tag. Patient 5 is not breathing. You open their airway and they start breathing. You're done. You don't need to do any further assessment. They're red. So you go through and you triage all your patients. You do this very simple initial green, red or black, and yellow. And then you've got them all sorted. And hopefully other resources have shown up by that point. You're not the only one there. But if you are, what do you do next? You begin treatment. So you go back to your reds. And now amongst the reds, you sort who's the sickest and you start treating them. Once you have treated or moved all of your reds to your treatment area or your transport area, then you go to the black tag patients. You're expecting them to die, but you may find in them some salvageable patients. And so you can go ahead and do interventions at that point, and who knows, you may save some of these patients, but you don't put resources into them because your exam told you that you expected them to die until you have gone through and taken care of everyone who is immediate, who's red, who you would expect to live if they get interventions within 60 minutes. Some people would say you come back to the black tags after the yellow. The definition of yellow is that they have injuries that you don't expect to deteriorate for hours. And my feeling is that it's easy to get people into a black tag categorization who, it turns out, with some interventions, may do well. So I suggest going to the black tags first, because if it turns out that they're a mistriaged red, they need immediate interventions. Then you go to your yellows, you do your secondary triage amongst them, you treat whoever's the sickest, or you move them to the gathering point, the treatment area, the transport area. And then your greens, you need to do a secondary triage as well. And there you may treat them, or you may move them, or you may say you have no injuries at all and discharge them, but you need to keep track of what you do with them. When you begin moving them, you can move them to one of two places. You can move them to your treatment area, where they'll get a tertiary triage and more intensive treatment, or to a transport area if there's transport available or no treatment area is available. So in that case, you've got, say, you're on this fishing vessel, there's the fire, there's the explosion, there's really nowhere to take care of the patients there. You may begin moving them onto your fast boats to get them back to your ship and have a treatment area set up on your own ship. Now, this is, what I'm about to say is not classic start triage. When we talk about the interventions we can do, we talk about opening the airway and either categorizing them as black or red. You could add to that, if they have exsanguinating hemorrhage, control exsanguinating hemorrhage during your initial triage. Start triage doesn't have that in there, but these triage plans, the SALT triage plan actually has you doing much more extensive intervention, controlling hemorrhage, decompressing the chest, giving antidotes to nerve agents while you're doing your initial triage. And that's also potentially appropriate. So you need to make a call about what interventions you can do really quickly. Someone's bleeding from a wound on their leg, they're unresponsive, you have a tourniquet, it will take you 30 seconds to put the tourniquet on, and that probably will stop the bleeding and may well save their life. If you've got it there and it doesn't delay you quickly treating them and then moving on through the rest of your triage, I don't see any reason why you shouldn't do that. If you've got a pocket full of oral airways and people are having trouble breathing, slip the oral airways in. These are all things that you have to make a decision how much they're going to impact your ability to go through and do your initial triage. Anything that's going to keep you there, you shouldn't do. So for example, someone's not breathing, you don't start rescue breathing or bag valve mask ventilation. You don't start CPR if they have no pulse, because that keeps you from moving on. But if you can do something really simple, putting on a tourniquet, putting in an oral airway, using a needle to decompress a chest if someone's got chest trauma and severe trouble breathing, or even if you think there's a nerve agent event and you happen to have Mark 1 kits and you're able to do the antidotes, giving those shots and then moving on. You don't wait to see the results, you don't do anything else. That's acceptable, but it's not pure start triage. Please complete any associated knowledge reviews, and if you have any questions, don't hesitate to contact your professor or instructor. Thank you very much.